طيب نبدأ.
توكلوا على الله.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here again in this scientific event under the umbrella of the Saudi Society of Family and Community Medicine, where we are going to explore a very important topic today that is related to a major health issues that is relating to, and in fact, it's very important to our aging society. And just before we start, let me just pave the way and set up the stage by saying that as we age, usually our body undergo many changes, and the respiratory system is no exception at all. The lung loses its elasticity, and the chest wall becomes stiffer, and the immune system usually gets weakened as we grow up. And this is the major point that subject our populations of elderly patients to the risk of contracting infection, and this make our older populations are vulnerable to a range of respiratory illnesses. And as you witness nowadays, ladies and gentlemen, in the past couple of months, there was a huge number of patients who had been exposed to upper respiratory tract infection, and majority of them, they were populations of elderly groups. And usually those people who have chronic conditions like chronic obstructive airway disease and pulmonary fibrosis, on top of it, they have some kind of acute infection like influenza, COVID-19, and respiratory syncytial virus as well, which impact, in fact, the quality of their life and subject them to be vulnerable to get hospitalized, and some of them, they might complicate to the devastating spectrum of the disease to be a patient in the ICU that mandated them to have some mechanical ventilation and subject their life to the threat of death. So that's why, ladies and gentlemen, today we are going to shed light on one of those important respiratory tract infections, which is respiratory syncytial virus. So I would like to welcome you here today in the RSV Masterclass Expert Case-Based Edition. And this is, as I told you, it is under the umbrella of the Saudi Society for Family and Community Medicine. And I would like to thank GSA Company for providing us this wonderful opportunity to be here today to discuss this topic. And I would like to thank Faxis Company for organizing this this platform and the gathering for us today. So before I start, I would like to mention certain important points that please, for optimal experience while scanning the QR code during the sessions, we kindly recommend to use the PC or the laptops, because there will be some kind of QR codes that you have to have it scanned by your mobile. So make sure that you are using the PC and the laptop. Always remember that you can put your questions in the Q&A box, so I'll be able to collect them and provide it to our expert to answer it at the end of the sessions. Ladies and gentlemen, today we are privileged to have our wonderful experience in the field of infectious disease, and with a special focus on the respiratory syncytial virus, Dr. Reem Al Amir. She's a consultant transplant infectious disease, King Saud University, King Faisal Special Hospital Research Center, Riyadh, in the Kingdom of Saudi Arabia. She has been with us for many, many times, exploring the different areas of respiratory syncytial virus. And today she is going to highlight a lot of issues regarding the screening, the diagnosis, and the treatment and the prevention of respiratory syncytial virus. So without any further ado, on your behalf, I would like to welcome Dr. Reem for accepting our invitations, and I would like to leave the floor for you, Dr. Reem.
Thank you so much, Dr. Ashraf. It's always a pleasure to have you as a moderator of our sessions, and thank you, GSK, for putting together this very important lecture about a virus that I think it's under-recognized in our community. So let me just share my slides so we can get started. 1 second. Let me know if you see them.
Yes, we can see them. Yes.
Right. So these are my disclosures. Today, I'm going to be covering certain points about respiratory syncytial virus, and from now on, I'm going to refer to it as RSV. So we'll touch base about the associated disease with RSV, then we'll talk about the short and the long-term impact of RSV, specifically in older adults. We'll talk a little bit about the cardiorespiratory complications and conditions in those patients who get infected with RSV infection. And lastly, we'll talk about diagnosis, management, and prevention of RSV. So we'll get started with the case. This is a case that I think most of us, as primary care physicians, family physician in the emergency room, us at the end where we see the infectious disease consultation, we have seen those cases. So Mr. Umar is in his late 50s. He has multiple comorbidities. As I mentioned, this is a very common scenario. He has diabetes, hypertension, dyslipidemia, some ischemic heart disease, valvular heart disease. And he presented to the emergency room with dyspnea, cough, and fever, no other positive symptoms. His initial assessment in the emergency room, he showed that he had a temperature of 38.2. He was desatting on room air to 88%, which was corrected by 3 liters of nasal cannula. He did have bilateral crackles in an examination, more pronounced on the right side, but no lower limb edema. And this is the chest X-ray you see on the slide. So, of course, the initial assessment was community-acquired pneumonia in this adult with multiple comorbidities, but the etiology at that point was not clear because, as all of us know, community-acquired pneumonia can be viral and can be bacterial. This is his initial labs. He did have acute kidney injury on top of chronic, so this is his creatinine, and this is the initial troponin test. So what we did, we started him on antibiotics. We did send for a respiratory multiplex PCR from the nasopharyngeal swab, and we did a series of ECG and troponin, just keeping in mind his background of cardiovascular disease. Unfortunately, in 48 hours, he started to worsen. He continued to be febrile with no improvement on the current antibiotics. So the antibiotics were broadened, and this is his chest X-ray. So we did a series of troponin on him, and you can see how the troponin is going up with time. So an echo was ordered, and again, it did show a grade 1 diastolic dysfunction, but nothing out of usual. Day 3, this is the X-ray. It continued to do worse, and eventually his respiratory multiplex came back to be positive for RSV. So he was diagnosed with severe community-acquired pneumonia with troponin leak secondary to RSV viral pneumonia. So this takes me to the idea of what is RSV. So RSV is a very contagious seasonal virus that co-circulates with other respiratory viruses. So we're all aware about the season for influenza, but no one remembers to mention RSV as well. So in the northern hemisphere of the Earth, usually RSV and influenza do peak through the winter season, and it starts to go down during afterwards in the summer times. However, this is a little bit different in the tropical area, where you can see rates or little outbreaks of or surges of RSV throughout the year, even in the summertime. And this is really important for us to understand in the region because tropical zone applies to us more than the northern hemisphere. This was a little bit disturbed and changed during the pandemic, where we have seen possibility of like outbreaks of RSV throughout the year. It is usually transmitted through inhalation or contact with respiratory droplets from those who are infected. And this is a very important concept because once RSV enters the house, all the household contact can be at risk for acquiring RSV infection. The R0 is a term that we use as infectious diseases. It just means how infectious the virus is. And R0 means, for example, for RSV, it's 3. So it means one infected person can infect at least 3 other people around him. So this is a very important concept to keep in mind, that how contagious the RSV virus can be. Another important concept, infected people are typically contagious for a week after the initial symptoms. However, in older adults, because they shed the virus for a longer period of progressive down because of the weakened immune system, so they can be contagious for a longer period of times. We always think of RSV as a disease for kids, and we tend to ignore it in adults, and that's not the case. RSV can infect anyone from young adults, babies, infants, and up to older adults. Usually, the extreme of age is where you see severe disease. So those kids under the age of 5 usually get very severe illness, and older adults as well, those who are 60 and above, usually will have severe RSV infection leading to hospitalization and in some cases death. The in between age group, those who are healthy, otherwise immunocompetent individual will have a self-limiting, short-lived respiratory illness in most cases. So RSV is like any other viral illness, which makes it tricky to predict if this is RSV or influenza or COVID, for example, because all of them will present usually with the typical upper respiratory tract symptoms, like cold-like symptoms, sore throat, fever, fatigability. However, in older adults, this might progress further to cause a lower respiratory tract infection, so pneumonia, like our patient we just discussed, and this might exacerbate any underlying heart or lung conditions, and this might lead to hospitalization and increase the risk for death. So as I mentioned, this is just a summary slide. Patients who are at increased risk for severe RSV infection leading to hospitalization and death are usually those who are older adults. So we're talking about 60 and above, those with multiple comorbidities or at least one or more comorbidities. Mainly we're talking about asthma, COPD, congestive heart failure, coronary artery disease, diabetes, and chronic kidney disease. I'm stressing on this point because there's some questions, so I need you to focus and I want you to answer correctly. Of course, if you have a weak immune system, you're at risk for severe RSV infection that might result into hospitalization and high mortality. So back to our patient. So he continued to have fever throughout his hospitalization. Now we know he has RSV, he's on antibiotics, but we don't have any effective therapy for RSV itself except supportive care. And unfortunately, his oxygenation did not improve. On day 4, a rapid response team was called because his hypoxia was getting worse and he was placed on a high flow nasal cannula. You can see the progression of his chest x-ray. Fortunate enough for him, in 48 hours, he gradually started to improve clinically and radiologically, and he was discharged after 5 days. So we see how bad it can get. And as a physician, it's really nerve-wracking to see your patient suffering and getting worse, and you don't have even an effective therapy for them. And this is which takes me back to the idea of under-recognizing the issue of RSV. We always think about influenza and COVID-19, coronaviruses, but we never think about RSV as a reason for influenza-like illness in older adults. And as I mentioned, it's always thought that this is a disease for kids, but actually the annual burden of RSV, for example, in the States, it's much, much higher in older adults than in kids. If you can see the numbers, for example, RSV causes 58,000 kids to be hospitalized. On the other hand, 177,000 adults will get hospitalized with RSV infection. This is other than those who come to the ED or the outpatient visits. And then it causes 100 to 500 deaths among kids, but it causes much, much higher number of deaths among adults, around 14,000 death because of RSV infection. So it's a significant problem that we have to recognize. Again, this is just to stress on the point that RSV is an under-recognized issue in older adults, and it's associated with high incidence, high rate for hospitalization, and very high in hospital case fatality rate. So routine laboratory testing for RSV is really needed for us to be able to understand the burden of the disease locally and how our patients are handling this infection. Of course, the morbidity and mortality, because it causes severe illness in our hospitalized older adult patients, we have to talk about their morbidity and mortality. From this retrospective cohort study of hospitalized adult patients who are 75 and above, with RSV infection in Hong Kong. It's around 600 patients included. They did find a high all-cause mortality 1 month after the initial diagnosis and even after 2 months of the RSV infection. And a high rate of those patients ended up requiring oxygen. So around 70% of them required some type of supplemental oxygen, and 11% of them needed intensive ventilatory support for their oxygenation. So again, this is to stress that RSV infection in older adults might result into respiratory failure, prolonged hospitalization, superimposed bacterial infections because you're staying in the hospital for longer, and then high mortality rate. We always talk about influenza as the bad guy, and I always say that. Dr. Ashraf knows that, but I think RSV is the worst kid around in the neighborhood. So we have to think about it. If you compare RSV to influenza head to head, and that was done in one of the global prospective study, the rate of complications and mortality in adults hospitalized with RSV were compared to the rate of the same complications for patients who are hospitalized with influenza. And again, this was done in older adults, those who are above the age of 60. And you can see RSV is the orange, and then you have influenza is the blue. And again, the rate for lower respiratory complications, bacterial superinfection, cardiac complications, death during hospitalization was higher in RSV patients compared to the influenza cohort. Of course, we cannot talk about, geriatric population without talking about their quality of life and impact on the functional status. As any other respiratory infection, RSV does have a significant impact on the functional status and the quality of life of our older adults. From this study in the United States, they looked into those patients who are older, so 74 and above, who were admitted with RSV infection, and they looked into their functional status at discharge and then almost 6 months after discharge, and it was significantly impacted. 8% of those patients reported ongoing loss of independence after 6 months. And this, of course, comes with consequences. So around 24% of the patient required a professional home health care, up to 26 of them required readmission within 3 months, and around 1/3 of the patient actually died within a year of that admission. So we have a big chance here of impacting our patient's life by preventing this infection. And again, of course, because of all these hospitalization, the high mortality rate, and the respiratory failure, prolonged hospital admission, it comes with a burden on the healthcare system. And this was seen and documented in the literature where they looked into annual healthcare costs for adults with RSV versus matched controls. And you can see the huge number of money that was spent from the healthcare system on those infections. Now to the knowledge check. Is it me or Dr. Amir is going to do the knowledge check?
Yes, you can go ahead, Dr.
Okay.
Reem. Yeah.
So I'm not sure. Do they scan the code first or do they answer the questions?
They should scan the code. طيب, can you put the code, please? Yes.
Yeah, the QR code. You can scan it quickly. Okay. Go back to the question. So the first question, which of the following factor, okay, I can see the question. Okay, which of the following factor does not increase a person's risk of severe RSV infection? Age. So which one of the factors does not increase the risk? So is it age, presence of underlying chronic condition, family history of RSV infection, or a weakened immune system? Okay. And then the next question, RSV infection significantly impact the health of older, especially those with comorbidities. Is this statement true or false? Okay, and I think you can see the correct answer in the notes, and this is just to keep you awake with me. Okay. Now we'll move to the second section of the lecture, which is RSV and cardiorespiratory conditions. And again, we'll start with a case because us as physicians, we love cases, and this is what,
I think, Dr. Reem, this is the answers. And this is the first question: which of the following factors does not increase person's risk of severe RSV infection? So age was 28, presence of underlying chronic condition 7%, and majority they said family history of RSV infection is not a cause or a factor to increase the person risk of severe RSV infection. So this is the correct. Actually, aging and the presence of chronic conditions and weakened immunity are one of are the risk factors, in fact, to increase the risk for RSV infection among especially elderly patients. Yeah, next. This is the second question. Respiratory syncytial virus infection significantly impact the health of the elder, especially those with comorbidities. So almost 89% of the audience, they agreed that it is true. So, so this is the correct answer, that the infections impact those elderly patients with multiple comorbidities. Okay, thank you. So we can go ahead.
Good, good. So you guys are awake. Nice. So RSV and cardiorespiratory conditions. I'm going to start with a case again because we love cases as a physician. It just relate to our practice. So this is another older adult. He's a 72 years old gentleman, again with multiple comorbidities, diabetes, ischemic heart disease, with history of PCIs in the past and with a very low ejection fraction of 25%. He again presented to the hospital with 1 week history of progressive dyspnea this time. A week prior to this progressive dyspnea, he did have a viral prodrome of like sore throat, runny nose, and cough. He did report that one of his family members did have history of flu-like illness in the past 2 weeks. In the emergency department, he looked sick. He was very tachypneic, desatting, requiring 3 liters of oxygen. He had a lower limb edema, and he did have bilateral crepitations on chest examination. This is his initial labs. You can see that he did have a little bit of elevated creatinine, negative cardiac enzymes. This is the chest X-ray. There is bilateral infiltrate, maybe more to the right upper lobe rather than the other patches of the lungs. He did test negative for COVID and rapid influenza, but no one thought about sending RSV at that point. So the patient clinical status started to progress in the emergency room, and he started requiring high flow nasal cannula around 45 liters and was moved to the critical cardiac unit. He was covered broadly with antibiotics. And within 24 hours, we have the respiratory culture result, which came back negative. The blood culture remains negative up until that point, and the respiratory multiplex PCR came back positive for RSV. So this patient remained in the CCU for almost 10 days, managing his RSV infection that probably exacerbated his heart failure. So the impact of RSV on cardiovascular health is very significant, actually. For example, in the States alone, there is 160,000 admission or hospitalization annually for serious RSV infection. Around a quarter of them, so around 22% of those hospitalized patients, will develop a cardiovascular event. This could be congestive heart failure, acute coronary syndrome, or like atrial fibrillation. And underlying cardiovascular disease has also been linked to 45 to 60% of adult hospitalization with RSV infection. So it's kind of a bi-directional relationship. RSV will introduce cardiovascular events because of the infection, and patients with cardiovascular diseases, like our patient who had ejection fraction of 25%, were more likely to get admitted if they get RSV infection. And we think this happens because of the systemic inflammation, which is usually triggered by the respiratory viral infection, resulting into the release of pro-inflammatory cytokines. These will disturb the wall of the coronary arteries, resulting into inflammation, which will result into plaque rupture, thrombosis, and eventually leading to increased risk for a cardiovascular event. So there is evidence that RSV can directly induce a cardiovascular event, and patients with underlying cardiac condition can get worse when they get RSV infection. As I mentioned, and this is just to stress on the fact that around a quarter of the patient hospitalized with RSV will have a cardiovascular complication. So heart failure exacerbation, myocardial infarction, atrial fibrillation, and so on. Usually they're older adults, so they're about the age of 79, and this will greatly impact their 1-year survival rate afterwards. If you can see from the graph in front of you, the incidence of hospitalization for acute MI in the first 7 days of viral infection, so someone who's admitted with viral infection, first week of that admission, the rate of MI was high on those patients who had influenza RSV compared to other viruses. And chronic heart disease or underlying chronic heart disease as well impact the outcome of RSV infection. So those patients who had congestive heart failure at baseline, they're more likely to be admitted to the hospital if they get RSV infection. And unfortunately, they're more likely to die from this RSV infection. As you see from the graph here, blue have no congestive heart failure, and the orange have congestive heart failure. As you can see from the graphs, those with congestive heart failure, they're more likely to be admitted or hospitalized for RSV infection compared to those who did not have heart failure at their baseline. And the thing is, it does not impact your acute presentation, but RSV infection in those with congestive heart failure have been shown to impact the 1-year mortality or survival for those older adults. So patients with congestive heart failure or had an exacerbation of a cardiac condition because of RSV infection, they're more likely to die or have a worse mortality outcome within the first year after infection. So their 1-year survival is greatly impacted with RSV infection. So in summary, RSV may cause cardiovascular complication in older adults, and pay attention because we're going to have a question. So cardiovascular complication in older adults in the form of heart failure, atrial fibrillation, and myocardial infarction. Older adults with congestive heart failure or coronary artery disease to start with, they have a higher risk for RSV-associated hospitalization, and this usually impacts their 1-year survival rate following admission with RSV infection compared to those who did not have heart failure or heart failure exacerbation. Now we'll move to the respiratory RSV infections and the underlying COPD and asthma. So patients who get any viral infections, and if they have an underlying COPD or asthma, it's known that they usually present with worse clinical trajectory in general. So usually they have longer hospitalization, accelerated decline of the lung function, greater hypoxia. They might even have enhanced responsiveness to allergen and longer hospital admission in general. So RSV infection can exacerbate COPD, underlying COPD and asthma. In one study, the RSV has been detected in 10% of acute exacerbation of COPD. In other prospective study, RSV accounted for around 11 to 26% of hospitalization for COPD exacerbation, 7 to 13% for hospitalization with asthma exacerbation. So respiratory viruses during the acute COPD exacerbation, and this systemic review and pooled data on prevalence of respiratory viruses in patients with acute exacerbation of COPD from around 19 studies. So it's a huge number of patients, around 2,000 patients were included in this study. And they looked into which are the most likely viruses to cause a lower respiratory tract, to have a detected virus in their lower respiratory tract. And they found that rhinovirus, RSV, influenza were more frequently detected in the lower respiratory tract of those with COPD exacerbation compared to the upper respiratory tract samples. Again, this is a large prospective study that estimated the incidence of RSV-associated hospitalization from the United States, and they found that the rate of hospitalization among patients who are above the age of 50 are more likely to happen from RSV infection if you have underlying asthma, COPD, or cardiac conditions, as we just discussed. Another interesting observation from the literature is persistent RSV infection in patients with COPD is associated with accelerated decline in the lung function. Like from this study, they looked into repeated positive tests for RSV, meaning they had some kind of chronic infection, those patients with COPD, and this was associated with faster FEV1 decline and higher inflammatory parameters. And by declining FEV1, all of us understand that those patient function status and quality of life is actually worse. So just a summary about the respiratory condition. So older adults with COPD and asthma are at higher risk for severe RSV disease. High proportion of older adults hospitalized with RSV experience COPD and asthma exacerbation. So again, like a bidirectional relationship. There is persistent RSV infection is associated with a rapid decline in the lung function and higher airway inflammation, specifically in patients with COPD. Now we'll go to the second set of questions, and I think we have another QR code. Let me double check. Is it the same QR code?
Yes, they can scan the QR code now.
Okay, gonna move to the questions. So the first question, all of the following groups are at increased risk of severe illness due to RSV infection except iron deficiency anemia, chronic kidney disease and congestive heart failure, diabetes, asthma, and COPD. So who is at least risk for exacerbation with RSV or bad disease, let's say? Okay. To the second question. After full recovery from RSV infection, most individuals cannot get reinfected. Is this true or false? Okay.
Okay. So this was the answers. The first question is all the following groups are at increased risk of severe illness due to respiratory syncytial virus infection, except. So majority, they had the correct answer, 82% of the audience. So iron deficiency anemia is the least, but definitely diabetes, asthma, COPD, chronic kidney disease are factors, major factors, in fact, for the severity of the illnesses due to respiratory syncytial virus. So,
proud of you guys. Okay, next one.
So after full recovery from RSV infections, most individuals cannot get infected. The correct answer is false. Usually there is reinfections take place, and this is the fact that we have to remember all the time. One infection could be preceded by another infection, especially in those patients who are elderly with multiple comorbidity. So thank you. Majority of you got the right answer. Okay, we'll continue.
Just one more comment, Dr. Amir. The fact is, when we get respiratory viral infections, we don't get immunity. So we don't get immunity from getting the infection itself. It's not like when you get chickenpox or whatever. So this is totally different. So you can get RSV infection for this reason, because you cannot develop immunity from infection itself.
Yes.
Great.
Right.
So now we'll move to the last section of today's webinar, which is focusing on RSV diagnosis, management, and prevention. So again, I just want to stress on the fact that we have a huge burden of RSV in our community. However, it's a very under-recognized issue because RSV testing and diagnosis are not routinely considered for adults with influenza-like illness. And this was apparent even in the Western countries. So they did some surveys for infectious diseases physician in the States, and they did ask them about caring for adults with acute respiratory infection. And less than 50% of them recommended to order an RSV testing for those patients, even if they're coming with a COPD exacerbation. In another survey, again from the States, 57 of them responded, 57% of the physicians responded that RSV is rarely considered as a potential pathogen in patients who are older than the age of 50 with respiratory disease, and the majority said they don't test for RSV. So we have a huge problem here. I think we under-recognize the impact of RSV on our older adults as a causative pathogen for a severe respiratory illness, and we tend to forget about the testing. And testing is very crucial and important for so many points. First of all, RSV, as I mentioned earlier in our webinar, is highly contagious. So by detecting RSV infection, you enable the timely isolation of infected persons, so you avoid spreading the infection in the community. It might help you by diagnosing RSV to have an informed clinical decision and enable implementation of early intervention, which might improve the outcome. Again, it might improve the counseling of your patient and their families about prognosis and need for admission to the hospital and rehab services afterwards. And finally, it might help with a reduction of inappropriate use of antibiotics. We all live in the Middle East and we understand the impact of the overuse of antibiotics and how did it contribute to the great area of multi-drug resistant organism that we deal with on daily basis in our practice. So maybe by diagnosing more viral illnesses and knowing that those patients does not or do not need antibiotics, that might help in that direction. So diagnosis of RSV is usually by, the clinical suspicion. So when you have patients with influenza-like symptoms, which is it's really non-specific symptoms, I think we have to start testing our patients for RSV, and just to understand the burden of the disease and to implement the few things that I just mentioned in the previous slide. When it comes to management, and this is, I think, my major issue with RSV infection. For example, for influenza, we do have a treatment. We do have an antiviral, which is to some extent is effective in our patient population. However, RSV has no specific antiviral therapy, and this is the struggle. As a physician, you see your patient suffering and you don't have any specific therapy to give them, and usually it's mainly supportive care. And this takes me to the idea that prevention is key. So preventing RSV infection is our priority because till now we don't have a treatment for it. So prevention is key. So vaccine have already been approved for RSV, and it is available since 2023 for adults who are 60 years of age and above. And before that, before 2023, we did not have anything else to prevent RSV infection except some non-pharmaceutical infection prevention measures. So that takes me to the GSK RSV pre-F3 or pre-protein F3 vaccine. So this vaccine does have two components. The first component is the RSV pre-F3 antigen, which is the major component of the vaccine. And then the other component is the adjuvant system, which is the AS01, which is very similar. If you're familiar with the inactive zoster vaccine, it's the same adjuvant system. What does it do? This adjuvant system boosts the cellular immune responses and restores the CD4 T cell level in older adults, which is has a major important impact on the antibody response to the vaccine and the durability of the vaccination by giving this robust cellular immune response to protect our older adults from RSV infection. Of course, we're going to discuss in the next slide the trial that was conducted to test the RSV vaccine efficacy and immunogenicity in those who are older adults. So it is a randomized, placebo-controlled, observer-blind, multi-country efficacy study. Just to make it very simple, they randomized two groups of patients to either receive the vaccine in season 1 or not to receive the vaccine, just to receive a placebo. So this was season 1. And then in season 2, they tested the idea, do we need to give the patient a booster dose? So every year, do we need to give the patient a booster dose or not? So this is why they did the season 2, where they randomized patient who received the RSV vaccine to either receiving a second dose or to get a placebo. And then, of course, the patient who received the placebo from the get-go, they got the placebo again. And then they looked into the mainly the efficacy of RSV in prevention of RSV, lower respiratory, okay, focus, lower respiratory tract infection in adults who are 60 and above during the first season. So this is the primary endpoint. And then the confirmatory secondary endpoint is to demonstrate the efficacy of the RSV vaccine in preventing RSV lower respiratory tract infection in adults, again, 60 and above, over 2 seasons following a single dose of the vaccine. What they found is for the first season, and these numbers are very important, I'm just going to tell you from now. So the first season analysis demonstrated that the RSV provided a high and a consistent efficacy against the full spectrum of RSV disease, regardless of the RSV subtypes. If you want to know more details, we can talk about it. But for now, it did protect against the full spectrum of RSV, regardless of the subtype in adults who are above 60 and above. So if you can see the numbers, the first number represent RSV lower respiratory tract disease in those who are 60 and above, and the efficacy rate was 82%, almost 83%. And then to protect against severe RSV lower respiratory tract disease in 60 and above was 94%. They looked into if this 60 years old had a comorbidity, at least one comorbidity of interest, what would happen to the efficacy of the vaccine. And again, it did still show that it is very effective in protecting those who are older adults with one comorbidity or more of interest at a rate of 94.6% from severe lower respiratory tract disease. And they did look into the cohort of patients who are above the age of 70, actually, until the age of 79. And again, the RSV vaccine was very effective at a rate of 93.8% in protecting patients from RSV lower respiratory tract infection. And they did see that one dose of the vaccine, because we talked about the season, right? So seasons means annual dosing. So they looked at the efficacy of one dose, and they found that one dose of the RSV vaccines, actually the durability is effective to cover 2 or even 3 seasons as for the data that we have so far. And this is correct across all older adults with underlying comorbidities for protection from RSV infection. And when it comes to safety, it was very well tolerated with an acceptable safety profile. Someone should ask the question, because usually we're going to think about giving RSV vaccine in the next winter season, right? And we always think about co-administration of our vaccine with something else, like the influenza vaccine, because the patient, once they come to your clinic to get the vaccine, this is a golden chance to try to get the maximum vaccines at the same time so you don't miss them. So is it safe to give influenza vaccine with the RSV vaccine? So they did conduct a phase 3, again, open label randomized control study evaluating the immunogenicity and the safety reactogenicity of RSV vaccine when it is administered with or co-administered with either influenza, the quadrivalent, the standard dose, the high dose, or the adjuvanted vaccine. And again, they did see that co-administration of RSV with influenza vaccine did not show any evidence or clinically meaningful effect on the immunogenicity of either of the vaccine. The co-administration was very safe and well tolerated by our patient, and it's totally acceptable to give the RSV F3 vaccine with one of the influenza vaccination in the next winter season. Okay, let's move to the last knowledge check, as I believe. Now, I'll show you the QR code one more time for you to scan. Okay, and then we'll move to the questions. So this is a question about the vaccine itself. So RSV F3 vaccine is indicated for active immunization for the prevention of fill in the blank, because why RSV in adults, and then again fill in the blank the age, years, and older. So it is indicated to protect from which condition? Is it upper respiratory tract disease in those who are 60 and above, lower respiratory tract disease in those who are 50 and above, upper digestive system disease in 60 and above, or lower respiratory tract disease in those who are 60 and above? And I'll give you a minute because it's a tricky question. Okay, we'll move to the next question. So how did the vaccine perform? So this is a question about the performance of the vaccine. So the RSV pre-F vaccine delivers vaccine efficacy against RSV lower respiratory tract disease of percentage in patient aged 60 and above with one or more coexisting condition of interest. Is it 82%? Is it 86%? Is it 94%? Or is it 93%? Okay. Should we move to the answers?
Yes, you can go ahead, Dr. Reed.
So for the first question, so the RSV pre-F3 vaccine is indicated for active immunization for the prevention of lower respiratory tract disease in adults who are 60 and above. So the correct answer is D. I'm not sure about the statistics for this answer, but the D is the correct answer. And then for the percentage of efficacy of the vaccine in preventing RSV lower respiratory tract infection in patients who are 60 and above with one coexisting comorbidity, I believe C is the correct answer. Okay. And that's it for me. Thank you so much for listening. I think Dr. Amir will take you through the survey.
Yes, okay. Thank you so much, Dr. Reed. There's a satisfaction survey. Please make sure that you scan the QR code and just score how you scored your expectations towards this event. And now, Dr. Arim, I would like to start now the Q&A sessions. And in fact, we receive a good number of questions, in fact, and most of them are really practical ones. As you know, Dr. Arim, we have been privileged to host the mass gathering here in the kingdom in terms of Umrah and Hajj, where we host millions of people. How do you see the RSV infection will impact this kind of mass gathering? And what will be the role of the primary care physician to screen, to prevent, and even to treat those patients who might have the RSV infection?
That's a great question, because every time around this time of the year where we have the Hajj season, well, all of us are on alert and high alert, because we do understand that those pilgrims are coming from all over the world. They're going to be in this tight spot, with no much, infection prevention control over the whole crowd. And been recorded and documented in the literature that the rate for respiratory infections during these times do surge a lot. So it's all respiratory infections: influenza, coronaviruses, COVID-19, and of course, RSV infection. I think the best thing to do is probably patients who are expected to go to the Hajj season should have received the vaccine during the last winter campaign or the winter season. That would be the best bet to protect them from RSV infection. But if that was not done, then you have to explain to your patients, especially those with comorbidities. My concern and fear is for those who have COPD, asthma, underlying heart disease, that we know for a fact that they might get very severe illness requiring admission, and fortunately they might end up with high morbidity and mortality, is maybe to wear face mask during when they're doing all the Hajj related activities to teach them as well in these situations.
Okay, Dr. Reem, in primary care, because we are very much concerned about my colleagues who are working in primary care. In fact, we encounter multiple viral respiratory tract infections. So we get COVID, we get influenza, and we get RSV. So with the limitation of the resources of primary care, where we don't have any diagnostic tools, so what will be the way to have the proper diagnosis of RSV among these different varieties of respiratory disease based on the clinical symptoms? And are you going to screen everyone, or just only the high-risk populations who are more liable to get into the complication of RSV? So what's your thought on this?
So basically, for limited resources, and I understand that's something that we as well struggle with sometimes, you have to risk stratify your patients. So I would not test everyone. I would test those who are at heightened risk for severe RSV infection. So again, those with comorbidities, especially with underlying cardiorespiratory diseases. And we did have some, we did talk to a while ago about having a combined test for COVID-19 RSV. And I know it's available in some centers around the kingdom, but it's not available. That would be the way to have virus in one test and get cheaper compared to the respiratory multiplex. And I believe it's quicker. We don't have sources. Best thing is to discuss this possibility with the patient and to give them a contingency plan in case they get worse, where to go and how to.
Okay, Dr. Reem, for how many seasons the protection will last for RSV? And there is the new trials that show that there are an extension for additional season. So can you shed light on this, please?
So the initial data did suggest that the RSV vaccine durability will last for 2 seasons. So it will cover us for 2 years. So the patient will get one shot today. He will be protected for 2 years. I believe there is new data about season 3. So probably our patients, the durability and the efficacy of the vaccine lasts for 3 seasons. I'm not sure if that was published yet, but I know that there is data about even for now, you have to give your patient one shot and then don't think about it for the next 3 years.
3 years. Okay. If there is any specific time during the year where we have to encourage patients at risk to have the RSV vaccines, or throughout the year? So if there is any preferred times, and some people, they try to delay uh, the vaccination based on a certain season. For example, Ramadan came, and majority of the patients, they would like to postpone their vaccinations, while they might subject themselves, even during Ramadan, to the severity and of the infection, the complication as well. So just just shed light on this statement, please.
So I think the recommendation is to give RSV vaccine during the fall and winter season. So the same time of the usually where we give influenza vaccination, because we believe that this is the highest risk season requiring RSV infection. So I'm going to say from the beginning of September at maybe until April, or May, you can still give the RSV vaccine. I do think in our area, and this is something that we should talk about in our even local guidelines, we do actually see more respiratory illnesses during the summertime. It's not like the Northern Hemisphere. So until now, I seen influenza cases admitted to the hospital and RSV as well.
Yes.
Maybe our area is a little bit different, and you might give the patient the vaccine at the end of the winter season. That might give them the protection, but the recommendation is to give it in the fall winter season, which is from September until like April, like the influenza vaccine.
Thank you so much. And there is a very common question that can we co-administer the RSV with COVID and any other vaccines like Shingrix or even pneumococcal vaccine?
Yeah, so you can administer RSV with influenza vaccine, even like, RSV is for the RSV vaccine that we're talking about today is adjuvanted, and some of the influenza vaccine is adjuvanted as well, and it did not show that it impacts the immunogenicity or the efficacy of either vaccine, or even the side effect profile is very tolerable. So you can go ahead and administer both of them at the same time. Same thing for COVID-19. I think the CDC and the website, if you read, if you can co-administer these three vaccines together, and they do suggest that it is safe and tolerable to co-administer them. So you can go ahead during winter season, give your patient influenza and RSV at the same time. It should not be a problem.
Excellent, excellent. Well said. Beside the vaccination, Dr. Reem, what other preventive strategies do you recommend to reduce the RSV transmission?
It's
Apart
mainly
from
infection prevention, yeah. And it's mainly for inpatients. If we're talking about inpatients, it's usually infection prevention to try to prevent the spread of the RSV in the unit. For example, they should be on droplet precaution. Everyone should wear masks and hygiene, all that. But in the outpatient setting, again, hand hygiene is the first thing that comes to them.
okay, how about I'm sorry. Yeah, how about the complications of the vaccine? If there is any complications that might happen, this kind of fear of many elderly patients, any side effect of this vaccine?
Of course. So from the studies, even the safety profile of the vaccine, it was very safe and tolerable, but by most patients. Again, don't forget it does have a preventive system. Most of the effects will come from the preventive system itself, like the same idea with active sister vaccine. So most of the patients will complain of like pain at the injection site, some low-grade fever, fatigability, headaches, but usually they're short-lived, less than 48 hours, and most patients will do well after that. There's no major side effects except some neurological complication, but they're very rare in the studies. They were not that prevalent.
Yeah. How about the vaccine hesitancy, Dr. Reem? This is a major problem that we encounter, especially after the COVID. There is some kind of vaccine fatigue, and people are reluctant. Not only the patients and the community, even the doctors, they're not recommending vaccinations when it's come to RSV now. So, what's your strategy to combat this kind of problem?
So I run a vaccine clinic in my practice, and this is something that I face on a weekly basis, actually, with my patients. I find the best solution, and this is maybe I should not share that, but don't mention COVID, and everything will be fine. Uh, Seriously, because everyone is very reluctant when you mention COVID because of all the social media impact that happened during that time. But if you stress on the point, and sometimes it takes time for the patient to be convinced. So I found the best way is to sit with the patient, explain why do you think they need the vaccine from a scientific point of view. If they're not convinced, you can ask them to come again. So give them another appointment. And most of the time, my patients on their second appointment will accept the vaccination. But I'm not saying this is an easy process. It takes time. It takes time for the patient to trust you and to accept what you offer them. On the other hand, the healthcare professionals, I think this is why we do these webinars, just to educate and to assure our healthcare professional in primary care and any other sector, that these vaccines are effective and they are safe. And we have a huge burden of these respiratory illnesses in our community, and vaccination is the only way to try to control it.
Well said, Dr. Reem. And I think as a primary care physician, we have to spend enough time with our patients to convince them that vaccine will make the full protections and prevent serious complications. And I think we have to learn how to have the proper counseling for patients who have vaccine hesitancy, and to promote vaccine, to be a vaccine promoter. And not only to talk to the patient, but also to appear in the social media and even in the media to talk about vaccination and the importance of vaccination to protect our population at risk. So I think this is one of the important measures. So tackling the problem at the level of the community and the patients, and then do our job as a physician to be promoting for the vaccine. And then again, we go all the way to modify our health care system to become more appealing, to have this kind of encounter with the patient and the doctors, to have this kind of concept reinforced, and to have the insurance companies working hand in hand with us not to reject any kind of vaccinations orders, and to have the vaccine available in all the all the institutions. And nowadays they're talking about having vaccine in pharmacies like the one we had it a long time ago. So this is to enhance the accessibility of the vaccine across nationwide. So I think with this, Dr. Reem, thank you so much for being with us here today. And in fact, it was a very excellent presentations that you highlighted the whole issues of RSV by having two real-world clinical scenarios that you showed us very clearly how those people with heart problems or even chronic respiratory disease complicate aggressively to be a victim of serious complication of the disease that subject them to get hospitalized and even subject them for, God forbid, the death. So with this, I think it's very important for us to anticipate that respiratory illness is not a simple problem. It could be severe, it could be complicated with devastating consequences, especially for those people at risk. And we have to remember people at risk, those who are at more than 60 years of age, those who have multiple comorbidities, and we have focused on heart and respiratory disease. This is the most two important comorbid conditions. And then those who have problems with immune suppressed, receiving some kind of immune suppressions and so forth. So with this, ladies and gentlemen, I would like to thank Dr. Reem for being with us here today. And I would like just to highlight that I have one slide, if you can put my slide, so it will be a take-home message. And I think I have summarized it while I was talking, but please, can you put the slide? Okay, so of course, Dr. Reem, she have mentioned everything regarding the most important part that we have to learn about the RSV infection and protection, preventions, and even the treatment. But here I would like just to summarize the most important part that we have to take it as not take away a message, but a message that we have to take it to our clinic. So we have to say that RSV infection is often thought as a pediatric illness, but it is associated with a substantial burden in adults. So we are encountering both extremities of age, the children and the adults, and we have to put a special focus on the adults because they are very susceptible for the infection. Older adults with multiple comorbidities, and this is the clinical scenario that we encounter. We don't have patients who have only diabetes. We have patients who are elderly with diabetes, hypertension, heart problems, chronic obstructive airway disease. So these people at risk of, back again, okay. So these people at risk of RSV association hospitalization in comparison to those who don't have. RSV vaccine is available, and now it's available in majority of the primary healthcare center, and you can also request it through Sahati, and it's indicated for those people who are at the age of 60 years and above. The Saudi FDA have approved the use of RSV vaccine in 50 years and above if there is an increased risk of individuals for those people who are at increased risk. So with this message, I think it's very clear to understand that the vaccine is available, the vaccine is efficient, safe, and durable, and it will give us the full protections, which has been more than 94% for those people above the age of 60. So with this message, ladies and gentlemen, I would like to thank you for being with us here tonight, and I would like to thank the Saudi Society for Family and Community Medicine for being along with us in this kind of scientific activities. Special thanks goes to GSK for giving us this wonderful opportunity. And I would like also to thank the FEXs for organizing this meeting. Till we meet again, I wish you a good day, and let's hope for the best of being very competent to manage our patients with RSV using this vaccine. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. يعطيك العافية دكتورة ريم. Thank you.
يعطيكم العافية يا جماعة.
شكرا جزيلا.
شكرا دكتورة ريم، بارك الله فيك، أحسنتي، جزاك الله خير. نلتقي إن شاء الله دوما في مناسبات مفيدة وسعيدة إن شاء الله.
إن شاء الله. شكرا جزيلا على الفرصة.
شكرا دكتور ريم.
شكرا دكتور أشرف، حقيقة أمتعتنا بإدارتك الحكيمة اللي عهدناها في كل المؤتمرات.
الله
ما شاء الله تبارك الله، ولك
الله
إضافاتك الواضحة في كل يعني مؤتمر